Next, I would like to invite Dr. Karen from USA, and she will be speaking up on local anesthetic and adjuvants in children. She is the assistant professor anesthesiology and perioperative and pain medicine, Harvard Medical School. She is the director of pediatrics special interest group, American Society of Regional Anesthesia.
Okay, good morning. I'll try to talk quickly. Is it still morning? Yeah, no, it's not morning anymore, is it? Okay. I'm going to talk, I want to thank you all for being here and interested in the use of local anesthetics in children. It's always an honor to be here with Vrishali and with Dr. Bosenberg. And anyway, I should get on with the talk. Dr. Bosenberg did a nice job of setting up why we want to do regional anesthesia in children. And so now I can give you some of the recipes on how to do it. I'm just... Yeah, the white button. It's not on this one. I was just stalling a little bit, trying to figure out how to get these things to work. Okay, so the next slide. Okay, namaste. And I don't have any disclosures except, like Dr. Bosenberg, I am passionate about taking care of children and minimizing their pain. And so, you know, quick summary, as Dr. Bosenberg said, children have pain and regional anesthesia is very effective. So let's learn how to do it right. We do find that roughly 25% of the children are receiving regional anesthesia these days. And so that's a very large percentage of children to take care of. So just an overview of what I'm going to talk about, just a brief review of the different local anesthetics. I'm not going to get into the real details. We'll talk about some age-specific considerations, which are way more important in pediatrics than in adults. In the adults, they get to memorize just one dose fits all, and give those. In the kids, it's very age-specific. We can talk about when you do the dosing, where, how much, and then a brief talk about some of the adjuvants. Because regional anesthesia, because the local anesthetics wear off so quickly in children, we have to rely more on adjuvants to extend the duration. So there's not going to be a recipe. I wish I could just hand you a recipe book and tell you this is what we do. In fact, there are many variables in children. The age, and the one group that we really see a lot of pharmacologic differences are neonates and the infants. We see different comorbid diseases affecting what we do. And the different regional anesthetic techniques are important when you're considering the dosing, because neuraxial blocks are dosed much different than peripheral nerve blocks, and even within the peripheral nerve block group, there's different dosing guidelines. And it depends. We can talk about single injections and what you do if you have a catheter going. And here's the real crux of pediatric regional anesthesia, is what do we do with our infants and our newborns. So in terms of just briefly the local anesthetic choices that we have the esters and we have the amides. The basic difference between them are that the amides last longer. They do have a longer onset time. They do have increased toxicity, and they are metabolized via hepatic metabolism and renal excretion. The esters have a much shorter duration, and because of that, we don't really use them that often. They have a quicker onset time. They are metabolized by plasma cholinesterase, and they are more associated with allergic reactions than the amides. If there is an allergic reaction, there is no crossover between the amides and esters, so if you know which one caused your allergic reaction, you can just go to the alternate and be confident. So what I want to talk a little bit about is those infants that are 6 months of age and the particular physiology that we worry about with them. And so we know that the babies have, because they're infants, they're immature, and so everything's pretty much immature. We see decreased liver metabolism, they have low proteins, and the most important protein we worry about in the plasma of infants is alpha aminoglycoprotein. And they have a high volume of distribution, they're a higher percentage of water, and they have a much higher volume and higher turnover of CSF, which impacts their ability to have spinal anesthetics. So how these different physiologic changes, or how these physiologic nuances affect local anesthetic, is with the decreased liver metabolism, we have to worry about more. We worry more about accumulation with long-term infusions. With the low proteins, we worry about increased free drug, and it is the unbound local anesthetic that causes toxicities, and so we have to worry about that more in the infants because of the low proteins. Because of the higher volume of distribution, you know, there's sort of this yin and yang. With the increased risk for low proteins, we also see that with the boluses, that with a larger volume of distribution, that they tolerate the drugs and distribute it a little bit better. And we see a shorter duration of action of our spinal anesthetics in this age group in particular. So in this group, we have the esters. The adult people in the room are like, esters, what are esters? I don't use chloropropane. But chloropropane and the esters have a special place in pediatric anesthesia, especially in the infants. And what we know about 2-chloropropane is it's degraded by the plasma esterases and not dependent on that immature hepatic metabolism. It's not dependent upon protein binding for a margin of safety. And so it gets degraded very quickly by the plasma cholinesterases. It has a 20 to 30 second half-life in the plasma. In adults, it's 20 seconds. It's doubled in infants to 40 seconds, which actually has no clinical significance. When we try to do studies on plasma levels of 2-chloropropane, in fact, it's so short-lived that we have trouble doing pharmacokinetic studies. The downside is that there's only a 45-minute duration of action, and so that the applications are really limited to infusions. But since we do a lot of infusions in the infants, this has a unique place that we'll talk about when we talk about the infusions. Now, in terms of guidelines, I'm going to stand up here and try to tell you what kind of dosing we should be using in our nerve blocks for the babies. And there have been two very nice recent publications. One has been by the ESPA, the European Society of Pediatric Anesthetists, and they gave guidelines for postoperative pain management, and the European Society of Regional Anesthesia, in combination with the American Society of Regional Anesthesia, published their guidelines. These were published within months of each other, and they're both, if you're a pediatric anesthesiologist, these are must-reads for you, and really will tell you everything that I'm going to tell you in this talk. So, in terms of maximum dosing, we see that lidocaine, 7 milligrams per kilo, and the adults really don't worry so much about per kilo dosing. And then in the children, because of safety margins, because of the likelihood of local anesthetic systemic toxicity, the most important thing we can do in terms of being safe is make sure that we always calculate the dose of local anesthetic that we're giving, and make sure that we are not exceeding safe guidelines. And by the way, we talk about maximum safe doses here. This is not to be confused with the maximum bolus dose. The bolus dose for all of your nerve blocks is generally much lower than the maximum dose. And so always remember that when you're looking at these different guidelines. 7 for lidocaine, 2 to 2.5 for bupivacaine. Because of the more favorable cardiac toxicity profile with ropivacaine. The maximum dose is lower, or is higher, actually 2.5 to 3 milligrams per kilo. Levobupivacaine is available in Europe and again has the same safety profile as ropivacaine. And for the esters, although the manufacturer recommends 11 milligrams per kilo, the literature really supports 20 milligrams per kilo as a bolus dose in this age group. In terms of, this is going to talk about the volume, and so we talk about dosing, we can talk about milligrams per kilo, and we can talk about volume dosing. And so in terms of volume dosing, for the caudal anesthetics, for efficacy up to a T10 level, you want to give 1 ml per kilo of your favorite local anesthetic. In the lumbar region, because it's a smaller volume area, you have to reduce your volume to 0.5, and similarly, if you're in the thoracic epidural region, you have to reduce it to 0.3. You have to remember that local anesthetic is a space-occupying entity. Local anesthetic occupies volume, occupies space, and so you have to worry about what kind of pressure you might inflict on the spinal cord, and that's why these limits are in place, not because of local anesthetic toxicity. In terms of infusions, the recommended doses for lumbar, 0.2 to 0.4 mg per kg per hour. For thoracic epidurals, again, 0.2 to 0.4 mg per kg per hour. And your maximum here is 0.5 mg per kg per hour, but this is for older children. When you have children who are less than 6 months of age, because of those reasons we talked about with immature metabolism, you have to decrease this by half, such that the infusions really run at 0.2 to 0.25 milligrams per kilogram per hour in the babies. Okay, small infants and neonates, bolus doses unchanged, decrease your infusions, and this is where you want to consider your 2-chloroprocaine infusion in infants less than 6 months of age because of the concerns about accumulation. It has demonstrated efficacy as an infusion. It's been reported for use in a continuous caudal anesthetic, continuous epidural, continuous paravertebrals, and anecdotally for use in other peripheral nerve blocks. The nice thing about this, in addition to the lack of toxicity, is you can run the rates higher. Your maximum dose for an amide is 0.5 mLs per kilo per hour, and you can go as high as 0.7 mLs per kilo per hour with the chloroprocaine because of the safety profile. So again, if you have a volume-dependent block, you have a little bit more margin of safety to up your dose with chloroprocaine. Where do I point it to? Okay. Okay. Fine. In terms of, okay, so we talked about the dosing of local anesthetics. Now let's talk about adjuvants, because these blocks work so quickly, they wear off so quickly in the children. And by the way, we have good data in spinal anesthetics in kids and in neuraxial blocks. We don't really have good temporal data looking at the peripheral nerve blocks, so we can only assume that in the youngest children that they're also wear off more rapidly. But in terms of the adjuvants, some of the adjuvants that we have available for perineural use, these have all been tested and used for efficacy. Clonidine for spinal anesthesia will increase your duration. The usual duration of a spinal anesthetic using an amide is 60 minutes. You can get up to 90 minutes if you add 1 mic per kilo of clonidine. For caudals, you can increase your amount of time by 4 to 6 hours by adding 2 mics per kilo, and likely with the peripheral nerve blocks, although that data is a little bit less convincing. With morphine, by giving 10 to 30 mics per kilo in the caudals, we see an increased duration, and for the peripheral nerve blocks, we see with dexmedetomidine, if you give 1 mic per kilo, we're actually seeing an increased duration by about 3-fold. For intravenous adjuvants in kids, we don't have good data on IV dexamethasone, but the adult data supports giving 0.1 milligrams per kilo as a bolus dose. All of these adjuncts in animal studies, if you give them with your local anesthetic, they do increase local nerve toxicity. We haven't seen that be clinically significant, but the caveat being that whenever you do an adjuvant, always use the lowest possible dose because of the lack of data. We do worry about apnea with both clonidine and morphine in some of the smaller babies when you add it. With clonidine, the data was a meta-analysis, 1 to 2 mics per kilo. They saw, again, the prolongation of 4 hours, no difference in side effects, some somnolence, but apnea reported after small infants. With the dexmedetomidine, there's a nice meta-analysis of 21 clinical trials showing a 2.5 to 3-fold greater duration of analgesia. Now, the thing with dexmedetomidine is we don't have a lot of data, and with rat sciatic nerve, there was no histologic changes at 24 hours and at 14 days, but in rabbits, if you gave 10 times the dose epidurally, there was evidence of demyelination. So the jury is still out on what exactly this means in infants. Ketamine is not recommended because it does cause direct spinal cord toxicity in animal models. I don't really have time. 20 minutes isn't really enough time to talk about everything that needs to be talked about. With spinals, the more you do, the better you become at it. Again, if you do your adjuvants, you can increase your duration up to 90 minutes. If you do an ultrasound, it can help you with localization of where to put the local anesthetic. This is an image of the cauda equina, the conus medullaris ending here. And you can see right at the conus medullaris, you can avoid neurotissue by giving your local anesthetic right here at the bottom of the conus medullaris. In general, if you're looking at the nerve, your dose is 0.1 to 0.2 mLs per kilogram. If you're in a fascial plane, you want to give 0.25 to 0.5 mLs per kilo. This chart is in the ESPA guidelines, and if you ask me, I can send you a copy of my talk as well. And so I hope that in this brief amount of time that I've thrown a little bit of clarity on this and given you some guidelines to use in pediatric regional. Is there time for questions?
No, actually.
Okay.
Thank you very much.
Find me after.
Thank you very much.